Imagine for a second that you were taking your young child to the doctor.
Right.
They've been complaining of just severe pain, and they have bruising in their most private areas, and you've even found blood in their underwear.
Which is terrifying.
You are absolutely terrified. You are desperately seeking medical help. But instead of getting a diagnosis and, a prescription, you suddenly find yourself sitting in an interrogation room under investigation for child abuse.
It is, it's an absolute nightmare scenario.
Yeah.
And yet it is the tragic reality for countless families dealing with a disease that is quietly, systematically dismantling the body's tissues from the inside out, all while masquerading as external trauma.
That is just staggering. And I mean, it's exactly why we're pulling this topic out of the shadows today.
Absolutely.
Welcome to today's deep dive. We are looking at a towering stack of clinical guidelines today. We've got comprehensive sources from the British Society for the Study of Vulval Disease, or BSSVD, the NHS in the UK, and the Mayo Clinic.
Very heavy hitters.
Right. And all of this is to unpack a chronic, highly misunderstood, and heavily stigmatized skin condition called lichen sclerosus, or LS.
And this is incredibly important material for you to understand, whether it's for yourself, your children, your partner, or just, to be a more informed human.
Yeah, for sure.
It's a condition that carries immense physical and psychological weight, precisely because it happens in the parts of our anatomy we are taught to keep hidden.
Exactly. So the primary mission of this deep dive is to understand the actual mechanics of this condition, who it truly affects, and to answer a very specific, often overlooked question that we just see popping up time and time again in the data.
Which is a crucial question.
It is. Can lichen sclerosus affect the anal area? Because understanding the mechanics of our bodies, especially the parts we definitely don't talk about at dinner parties, is the ultimate tool for health advocacy.
Okay.
Let's unpack this. Before we can even begin to understand where this condition strikes, we have to understand what it is actually doing to the skin on a cellular level.
What's fascinating here is the underlying mechanism, because it entirely flips our understanding of skin damage.
How so?
Well, usually skin damage comes from the outside, right? A scrape, a burn, maybe an infection. But lichen sclerosus is fundamentally a chronic inflammatory dermatosis.
Okay, meaning what exactly?
What that means is your own immune system goes rogue. Specifically, these inflammatory cells, called T cells, start gathering precisely at the border where your two main layers of skin meet.
So they just congregate there?
Yeah, right between the epidermis on the surface and the dermis underneath.
Like an unwanted microscopic army just sitting at the borderline?
Exactly like that. And once they are entrenched there, they start releasing these tiny signaling proteins called cytokines. Now, in a normal immune response, cytokines are helpful.
Right, they fight off the bad stuff.
Right. But here, they completely upset the natural balance and renewal process of the skin. They create an environment of just chronic inflammation. And the most prominent result of this is something called epidermal atrophy. The top layer of your skin actually becomes abnormally thin and fragile.
Okay, let me try to visualize this. I like to think of the skin's layers like a house.
Oh, I like that.
The dermis underneath is the foundation and the scaffolding. The collagen, the support structure that gives the house its shape.
Right.
And the epidermis on top is the roof. So with lichen sclerosus, it's like the immune system is mistakenly attacking the scaffolding.
Yes, exactly.
It's breaking down the structural integrity from the inside. And because the scaffolding is failing, the roof, the epidermis, becomes paper thin and basically ready to cave in.
That is a perfect way to visualize it. You are literally losing the architectural support. And the sources point to some very specific biological culprits driving this structural collapse.
What kind of culprits?
Well, recent evidence has shown that patients with LS often have autoantibodies attacking a very specific protein. It's called extracellular matrix protein 1.
Extracellular matrix protein 1. Okay, what does that actually do?
Think of it as the literal glue holding the skin's architecture together.
Oh, wow.
Yeah. When your immune system attacks that glue, the skin loses its elasticity and its thickness. This is why we see strong genetic and autoimmune factors at play here.
So it's not just an isolated skin thing.
Not at all. In fact, for women with LS, there is a significantly increased frequency of other autoimmune disorders occurring at the exact same time, like thyroid disease or vitiligo.
Vitiligo, which is the condition that causes A loss of skin pigment, right?
Yes,
Yeah.
it's all part of the body's defense system just getting confused.
And that brings up a massive misconception. I
Yeah.
mean, I think if you polled people who have even heard of lichen sclerosus, they would tell you it is strictly a condition that affects postmenopausal women,
Oh, absolutely. It is a pervasive myth and honestly a very dangerous one.
as it delays diagnosis.
Exactly. It severely delays diagnosis for everyone else. While the incidence rate does peak in postmenopausal women, up to 15% of all cases are actually in prepubertal children.
Wait, 15%.
Yes.
That is a huge proportion of kids dealing with an autoimmune condition that most doctors associate with older adults.
It really is. And furthermore, it is not just a female condition. Men and boys can get it too.
Really?
Yes, in males, the medical community sometimes refers to it clinically as balanitis serotica obliterans.
Okay, balanitis serotica obliterans. That sounds incredibly intense. Break that Latin down for me.
It sounds intense because the physical reality of it is intense. Let's break the term down. Balano refers to the glands, or the head of the penis.
Okay.
Itis means inflammation. Xerotica literally translates to drying out. And obliterans means obliterating or destroying.
Destroying, wow.
Yeah, so you have an inflammation that dries out and literally obliterates the normal anatomy through scarring. It predominantly affects uncircumcised males, often causing the foreskin to become tight, scarred, and impossible to retract.
Okay, so if this is a systemic autoimmune issue, like if your body is circulating these autoantibodies and attacking its own glue, why isn't it happening everywhere?
That is a great question.
Like, why does it seem to localize in such specific, sensitive areas rather than just breaking out all over your arms, your back, or your face?
That is the million-dollar question in dermatology,
Yeah.
and it really speaks to the unique localized environment of the intergenital skin.
Okay.
Now, to be clear, you can get extragenital LS. About 10% of women will get these white, crinkled patches on their breasts, thighs, or shoulders.
Oh, I didn't know that.
Yeah, but those autoantibodies absolutely love the genital region
Why there?
because that skin is subject to a unique combination of environmental triggers. First, occlusion, meaning the area is closed off, it's warm, it's covered by clothing.
Right, it doesn't breathe.
Exactly. Second, moisture. Third, it is constantly exposed to irritants like microscopic amounts of urine.
Oh, that makes sense.
These local environmental factors seem to create the perfect storm, essentially putting a target on that specific skin for the circulating autoantibodies to strike.
Which perfectly sets up the core focus of today's deep dive. We've established that it heavily targets the vulva and the penis. But what about the geography beyond that?
Right.
Does lichen sclerosus affect the anal area?
To answer that directly, yes, it heavily affects the anal and perianal area, particularly in women and children.
Wow.
The NHS and BSSVD clinical guidelines are unambiguous about this. In women, about 3 out of every 10 cases involve the skin around the anus.
3 out of 10.
And here is a crucial detail that often gets missed. Sometimes it only affects the perianal skin.
Wait, really? Only the perianal skin?
Yes, you could have a completely unaffected vulva, but severe active LS right around the anus.
If you are listening to this right now and you've been silently dealing with agonizing anal irritation, just assuming it's hemorrhoids or a hygiene issue, that statistic alone should be a revelation.
Absolutely.
But the sources describe a very specific visual marker when it does affect both areas, right? Dermatologists have a name for it.
Yes, dermatologists specifically look for what they call the figure of 8 pattern.
Okay, explain what that looks like.
If you imagine the number 8, the top loop encircles the vulva, the lines cross down the perineum, and the bottom loop completely encircles the anus.
Okay, I can picture that.
Inside that literal figure of 8, you will see the hallmark visual signs of LS, pale, ivory, or porcelain white plaques of skin that look shiny, crinkled, and atrophic.
Here is what I am trying to wrap my head around. Why a figure of 8? Like, why that exact shape?
If we connect this to the bigger picture, the shape isn't an accident. This brings in a fascinating, albeit frustrating, concept called the Koebner response, or Koebnerization.
The Koebner response, okay.
In certain skin conditions, physical trauma or friction to the skin actually summons the autoimmune disease to that exact spot.
So the friction is basically putting up a neon sign for the T cell saying, hey, come attack over here.
Precisely. Now think about the anatomy of the figure of 8. The top loop is where tight underwear seems rub. The crossover on the perineum is where a bicycle saddle puts pressure. The bottom loop around the anus is subject to the daily friction of wiping with toilet paper or the mechanical stretching of going to the bathroom.
That is wild.
The daily mechanical habits of our lives literally draw the map that the disease follows.
The mechanical friction maps the disease. So let's talk about what that disease actually feels like. Because we usually think of a rash as something that sits on the skin and just feels itchy.
Right, but this is different.
Yeah, because LS destroys the structural integrity. Because the roof of the house is caving in, what does this actually mean for daily life?
It means everyday mechanics become agonizing. The primary symptom in the anal area is severe itching, and it is notoriously worse at night, drastically disrupting sleep.
Oh, that sounds awful.
But because the skin has thinned out so much, it loses all its elasticity. It becomes described in the clinical texts as cigarette paper-like.
Cigarette paper. So the moment you pull it, it tears.
It tears incredibly easily. Patients develop what are called fissures. These are small, deep, highly painful splits in the skin.
Think about the mechanics of just going to the bathroom. If your skin around your anus has the elasticity of wet cigarette paper, the simple biological act of having a bowel movement is going to stretch and tear that tissue every single time.
Exactly. It causes severe, sharp pain during defecation, and it leads to bleeding. And I want to slow down here because the psychological and physical fallout of this is profound, especially in children.
Right.
Children with perianal LS quickly learn that pooping hurts. So what is their natural instinct? They hold it in.
Which leads to severe constipation.
Severe, chronic, terrifying constipation. It becomes a vicious cycle. They hold it so the stool becomes harder and larger.
Making it even worse when they finally go.
Exactly, which causes even more catastrophic tearing and trauma when their body finally forces them to go. For a parent, seeing your child in that much pain, terrified of the bathroom, or finding blood in their underwear is one of the most frightening things imaginable.
Here's where it gets really interesting and honestly incredibly tragic. The tragic irony is that the very symptoms meant to signal a medical condition put families through absolute hell.
It really does.
The parents are desperately seeking medical help for their bleeding, bruised child, and suddenly they are the prime suspects in an investigation.
And we have to acknowledge that doctors have to tread incredibly carefully because child abuse is a very real, very serious issue that they are mandated to look for.
Of course.
However, the guidelines from resources like Visual Dex and the BSSVD are explicit about how to differentiate the two clinically.
How do they do that?
Findings of confirmed sexual abuse are primarily associated with acute injuries, deep anatomical notches, or sexually transmitted diseases. LS, on the other hand, presents with very specific chronic markers if a doctor knows to look for them.
Like what? What should a doctor or a terrified parent be looking for to prove it's an autoimmune issue and not trauma?
You look for the hypopigmentation, those distinct pale porcelain white areas. You look for the atrophic, crinkly skin. And you look for telangiectasias, which are tiny, widened blood vessels or spider veins right at the surface.
Okay, so very specific visual clues.
Exactly. LS also causes submucosal hemorrhage, which means bruising or purpura, that is incited by almost zero trauma. Remember the Koebner response?
Yeah, the friction.
Just the light friction of walking or gently wiping with toilet paper can cause a dark purple bruise that looks like a blunt force injury.
And it's not just children who suffer from misdiagnosis or delayed diagnosis either. Adults hide their symptoms out of sheer embarrassment, or they get misdiagnosed for years.
Yes, constantly.
If you are listening to this right now and you have spent the last 3 years constantly buying over-the-counter yeast infection creams because you assume you just have stubborn thrush, you need to talk to a doctor.
Thrush is the #1 misdiagnosis adults give themselves. Or on the clinical side, they are diagnosed with a different but similar sounding autoimmune condition called lichen planus.
Lichen planus.
And it is vital for you to understand the difference because the treatment approaches can vary and the long-term monitoring is different.
Okay, so if I'm at the dermatologist, how do they tell the difference between lichen sclerosus and lichen planus?
The golden rule in the clinical guidelines is geography. Lichen sclerosus will affect the outer vulva, the perineum, and the anal area, but it never involves the internal vaginal mucosa. It completely stops at the entrance.
Oh, interesting.
Lichen planus, however, frequently attacks the mucosal lining inside of the vagina, causing severe internal scarring, and it often presents with painful erosions inside the mouth as well.
But wait, why does LS stop at the door? If it's in the blood, why doesn't it go inside?
That goes back to the cellular level we talked about earlier. Remember extracellular matrix protein 1?
The glue.
Yes, the glue. That specific protein that the autoantibodies are targeting is expressed differently in the keratinized skin on the outside of your body than it is in the non-keratinized mucosal tissue inside the vagina or the mouth.
Ah, I see.
The target simply isn't there in the same way, so the immune system doesn't attack the internal tissue.
That makes so much sense. It's a lock and key mechanism. But even on the outside, the damage from LS isn't just about thinning skin. The sources repeatedly use the phrase loss of natural architecture. What does that actually mean for the patient?
It means the chronic inflammation and subsequent scarring literally remodel the patient's anatomy over time.
Remodel it.
Yeah. In women, the inner lips, the labia minora, can shrink and completely resorb into the surrounding tissue until they disappear. The labia majora can fuse together in the midline.
That is severe.
It is. The hood of the clitoris can scar over and seal completely shut, burying the clitoris entirely, which obviously has profound impacts on sexual function.
Right. And what about in men?
In men, as we discussed with balanitis serotica obliterans, it causes phimosis, where the foreskin tightens so much it can't be retracted, and it can actually scar and narrow the urethra, making it physically difficult to urinate.
So it is fundamentally structurally destructive. Okay, so if the body is actively remodeling and destroying its own architecture, how on earth do you halt that? You can't just put a bandage on an immune system that's attacking itself.
The first thing every patient needs to hear is that there is no permanent cure for lichen sclerosus. It is a chronic condition.
Okay.
However, it is highly, highly treatable. The gold standard of care universally agreed upon by the BSSVD, the NHS, and the Mayo Clinic is an ultrapotent topical steroid ointment.
Okay, steroids.
The most common one prescribed is clobetasol propionate at a 0.05% concentration.
Wait, hold on. I have to push back on this. If the disease makes your skin as thin and fragile as tissue paper, why on earth would the gold standard treatment be an ultra-potent steroid?
It sounds counterintuitive, I know.
Because we are always told by doctors that using steroids long-term thins the skin. That sounds like pouring gasoline on a fire.
It's a brilliant point, and it's the exact paradox that causes so many patients to stop their treatment. But dermatologists emphasize this constantly. Active lichen sclerosus will cause far more permanent, irreversible damage, the scarring, the fusing, the anatomical loss, than the steroid ever will.
Oh, really?
Yes, the thinning caused by the disease is entirely different from the thinning caused by a steroid. When you use the ultrapotent steroid on Ellis, it suppresses the autoimmune fire. It stops the T cells from releasing those destructive cytokines.
Okay, I follow you.
And ironically, once the fire is put out, the skin is actually allowed to heal and regain some of its normal thickness and elasticity.
Ah, okay, I see. I think of it like a firefighter dealing with a massive house fire.
Yeah.
You don't just walk up with a spray bottle. You need a massive high-pressure hose to put out a raging blaze.
Exactly.
But once the primary fire is out, you can't just pack up the truck and drive away because the embers are still incredibly hot. You have to leave a sprinkler system on to stop it from reigniting.
That analogy maps perfectly onto the clinical tapering regimen. Doctors don't just hand you the steroid and say, use it every day forever. There is a very specific, calculated timeline.
Right, the BSSVD outlines this tapering phase in detail.
Yes. The induction phase, your high-pressure hose, usually involves applying a pea-sized amount of the ointment every single night for 4 weeks.
Okay.
Then you step it down to alternate nights for another 4 weeks. Finally, you reach the maintenance phase, the sprinkler system, which is usually applying it just twice a week, long-term.
And a little really goes a long way. The guidelines say a standard 30-gram tube should actually last a patient anywhere from 3 to 6 months. If you are going through a tube a month, you're using too much.
Far too much, yeah.
And there's a pro tip in the sources. Ointments are vastly preferred over creams. Why is that?
It comes down to the chemistry of the vehicle. Ointments have a greasy, petroleum-like base, which acts as a protective barrier on top of the skin.
Okay, and creams?
Creams, on the other hand, are water-based. To keep a water-based product stable sitting on a shelf, you have to pack it full of preservatives. For skin that is already heavily compromised and full of painful micro-tears from LS, those preservatives in creams can sting terribly and actually cause contact dermatitis.
Oh, that makes total sense.
Yeah, ointments are much gentler and safer for this condition.
But there is another fear, a much darker one, associated with LS that the sources do not shy away from. And it's one of the main reasons that maintenance phase is so important, the cancer risk.
This raises an important question about long-term management, and we need to address it soberly but calmly. Genital and anal lichen sclerosus does carry an increased risk of a specific type of skin cancer called squamous cell carcinoma, or SCC.
What are the actual numbers on that? I know people hear the word cancer and completely panic.
The risk is under 5%. So statistically, more than 95% of people with LS will never develop this cancer.
Okay, that's reassuring.
However, That less than 5% risk is significant enough that long-term medical follow-ups are absolutely mandatory. Patients must be taught how to do regular self-checks with a mirror.
And what are they looking for?
They aren't looking for the standard white LS patches, they're looking for changes. A non-healing ulcer, a sudden new lump, or a thickened, warty area that does not respond to the steroid ointment.
And management isn't just about the medication either, as we talked about with the Kobner response. It's about minimizing mechanical stress,
Right.
using bland emollients or moisturizers to create a physical barrier against urine, wearing loose clothing. The European guidelines even note that wearing silk fabric underwear may reduce the need for topical steroids because it almost entirely eliminates microfriction.
That's amazing.
Silk underwear as a legitimate medical intervention.
It really shows how holistic the management needs to be. You are managing the immune system, but you are also managing the physical environment the skin lives in.
Let's bring this all together. We started by looking at a stack of clinical data to understand this condition, and specifically, its reach.
And we've seen that lichen sclerosus is far, far more than just a simple skin rash. It is a complex, structural autoimmune condition that essentially degrades the skin's architecture from the inside out.
It can severely impact the anal region, answering our core question with a resounding yes, causing agonizing symptoms that disrupt the most basic human functions, like sitting, sleeping, or going to the bathroom.
Exactly.
It leads to tragic misdiagnoses, like the horrific confusion with child abuse, and it carries a small but very real cancer risk.
But the overriding message from all these medical sources is one of hope and management.
That's the key.
With the right diagnosis, the diligent use of ultrapotent steroid ointments, and regular self-monitoring, that architectural damage can be halted, the symptoms can be completely controlled, and patients can reclaim their quality of life.
And for you listening, this is exactly why we do this. Knowing the difference between a stubborn yeast infection and an autoimmune structural change like lichen sclerosus is the ultimate form of self-advocacy.
It really is.
Whether it's for yourself, your child, or a loved one, having the vocabulary to ask a doctor, could this be LS, can literally save years of silent suffering and irreversible damage.
Knowledge is the most valuable tool you can bring into an examination room.
Absolutely. And I want to leave you with a final thought to ponder today. We talked about the Kobner response, this incredible map-making phenomenon, where the physical friction from something as mundane as a bike saddle, the seams of tight jeans, or exposure to urine, actually triggers your immune system to launch a localized autoimmune attack.
Right.
We always think of immunity as this invisible internal chemical soup. But if our immune system's battleground can be physically dictated and manipulated by the daily friction of our clothing and our habits, how much of our broader internal health is being quietly dictated by the hidden mechanical stresses of our modern environments?
That's a great point.
When our skin's foundation starts dismantling itself, maybe it's not just an internal glitch, but a loud response to the quiet, constant pressures we put on it every single day. Something to think about. Until next time.